John, a 35-year-old software engineer, was labeled as having high-functioning autism because he struggled with eye contact and preferred working alone. But no one asked about his childhood. If they had, they'd learn he grew up in a violent household and used emotional detachment as survival. His autism was actually complex PTSD. Trauma wears many disguises, and when you don't ask the right questions, you miss the truth. It's not that diagnoses are useless. They can guide treatment, validate experience, and help with access to services. But they are not truths carved in stone. They are hypotheses, approximations, educated guesses at best. And in a system full of noise and bias, we must hold our labels lightly. Think about this. A study published in JAMA Psychiatry found that diagnostic agreement among psychiatrists for schizophrenia was only around 60%. That means 4 out of 10 patients could walk into a different clinic and walk out with a different diagnosis. Imagine that happening in cardiology or oncology. And yet, we build entire treatment plans on this unstable foundation. Now let's talk about culture. A Black teenager expressing anger is more likely to be seen as oppositional, while a white teenager might be seen as depressed. Asian patients often minimize symptoms due to stigma and end up underdiagnosed. Latin families may describe depression in physical terms, like fatigue or pain, and clinicians unfamiliar with this may miss the signs entirely. Mental health is deeply cultural, and yet we apply the same Western labels and DSM categories everywhere. It's like using one map for every terrain. It just doesn't work. Then there's the gender lens. Women are more likely to be labeled with personality disorders. Men are more likely to be labeled with substance use. But what if both are coping with the same root issue, childhood neglect, abuse, attachment trauma, but expressing it differently? The same tree, just different branches. And then there's the epidemic of overmedication. In the absence of time and nuance, pills become the shortcut. But many medications were approved based on short-term trials, not long-term outcomes. And they often target symptoms, not causes. A child acting out might be given stimulants, but what if he's reacting to domestic violence? A woman with panic attacks might be given benzos, but what if she's in an emotionally abusive relationship? Medication can be life-saving, but it can also be misused when it replaces curiosity. We need better tools, yes, but more importantly, we need better questions.